This is the Healthcare Education Transformation Podcast, a podcast brought to you by two physical therapists devoted to helping physical therapists and other healthcare providers become better educators to patients, students, the community, and each other by interviewing prominent and passionate people within the realms of healthcare and education. The Healthcare Education Transformation Podcast is intended literally for educational and entertainment purposes only. No clinical decision-making should be based on only one source, and therefore this podcast should not be used as personal medical advice. While care has been taken to ensure accuracy, occasionally mistakes and factual errors can be present, as we are only human. This is our journey on the road to becoming better educators, so get ready with your pen and paper as class is about to begin. Hey everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm Brandon Powen, and of course, as always, I am joined by my co-host, F. Scott Veal. And today we have the extreme pleasure of having one of the best PTs that I currently know. And I've been so blessed to work alongside him and learn from him in clinic as we both currently work together at the Virginia Center for Spine and Sports Therapy in Midlothian, Virginia. I'd also like to give a shout out to everyone at our VCSST team for the amazing work that everyone does every day. Now, for those of you who don't know a little bit about our guest, we have the pleasure of welcoming Dr. Andrew Rothschild. Now, for those of you who don't know who he is a 2006 graduate of VCU's Medical College of Virginia with his doctorate in physical therapy. He has been a physical therapist for 9 years, working in a variety of outpatient orthopedic clinical settings. He became a board-certified orthopedic clinical specialist in 2008 and received his manual therapy certification from the Ola Grimsby Institute in 2010. He went on to complete manual therapy residency and fellowship training through the Ola Grimsby Institute in 2011 and 2012, and became a fellow of the American Academy of Orthopedic Manual Physical Therapists in 2013. He has served as adjunct faculty and guest lecturer in the Department of Physical Therapy at Virginia Commonwealth University, VCU, and has also provided lectures at the University of Tennessee Medical Center in Memphis, Tennessee. And he has extensive training in spinal manipulation and dry needling and has served as a clinical mentor not only for students in PT school, but for physical therapists working towards their manual therapy fellowship. He is currently teaching for the Institute of Advanced Musculoskeletal Treatments, and he is a contributor to the Modern Manual Therapy blog. For fun, he also is a former college soccer player, and he also has a bachelor's in geography. But now, Andrew, first and foremost, thanks so much for all that you've done for the profession, for all of the students and clinicians that you have mentored. As you know, you're one of the best in the business that I've met. And you know, of course, I realize that I kept your bio pretty brief here, man. But you know, was there anything that you'd like our audience to know about you that I didn't mention in this brief intro?
First of all, if I'm one of the best you've met, you've got to go meet some more physical therapists. We'll start with that. But I think one other thing about me, I guess, that does serve from a clinical standpoint is just having gone through my own experience with surgery, rehab, and some persistent pain, having had spondylolisthesis and L4-5 fusion in 2000, so almost 17 years ago. And that's kind of what got me interested initially in physical therapy as a profession, and then dealing with my own bouts of persistent pain over the past 17 years kind of got me more interested in the persistent pain realm of things.
Yeah, that's awesome, Andrew. I love hearing those stories about what turned people on to physical therapy. And more often than not, it's people have had to go through the rehab themselves. So kudos to you, man. I love it. Andrew, what made you decide to pursue a residency fellowship, and what specifically was it about the Ola Grimsby Orthopedic Residency and Fellowship program that made you decide to apply there? And what did the overall cost of that program look like?
Well, this in my second position, I'd worked for a physician-owned PT practice right out of PT school for about a year and a half until I got a little bored and frustrated and moved on with a friend of mine who worked for one of the large corporate PT practices in the country. And we were fortunate that the director of clinical education for the entire company worked out of our office in Richmond, Virginia, and he had been a former instructor with the Ola Grimsby Institute. And I really didn't know much about it at the time. We really didn't have a significant amount of manual therapy in my initial PT education in PT school, I would say. Some very basic stuff, but really not a lot of really not a lot of immersion into the hands-on time. And even in some of my clinicals, I didn't get a great hands-on exposure. I got a lot of McKenzie exposure in one place and more exercise in another place and a little bit of hands-on stuff, but really nothing significant that I really felt comfortable or confident doing those things. And I was fortunate enough that the place I was working, they offered a sort of a 1-year COMT, so a manual therapy certification program that they essentially covered, I guess, paid for. And that was through the Ola Grimsby Institute. And so that was 1 weekend a month for a year, essentially. And that was my first exposure to it. And just the instructor I had, who later became my residency and part of my fellowship instructor, was just, he's the director of clinical research at the Cleveland Clinic. And he was just, he also has his PhD in neuroscience. So he was just unbelievably knowledgeable and just kind of talking all this stuff that I had brand new to me. I'd never heard before in my life, explained this way and applied this way. And it was just fascinating. And I realized just how interesting it was. And it kind of, some of the stuff that they taught, even though it was very brief, kind of just covering the surface and the certification, it just really kind of connected with me in a way that kind of just really made sense. And I just kind of bought into it, kind of hook, line, and sinker. And it was after the year of the certification course that a couple of people who were also in it got together and we tried to figure out how we could do a residency. And then all we had to, the way Ola Grimsby sets it up is they have certain ones going throughout the year. A lot of times there's one in Seattle, there's one in Cleveland. But they will, instead of always having it at specific spots, if you have enough people in a given area that are interested in doing it, they'll bring an instructor to you. So we were able to get enough people who were interested in doing it. The certification course was in Northern Virginia, but we agreed because a couple of people were from North Carolina. We ended up having it in Richmond, actually, so it was very convenient for me. We did all the coursework, the weekend lectures in Richmond, and then we had to do our one-on-one mentorship with a fellow or an instructor through the Institute in different parts of the country. So it just worked out that way. We had enough people to do it, and that was just that exposure was kind of what got us interested in doing a residency. And then again, those of us who did the residency, there was enough of us who wanted to do the fellowship, and we kind of just kept that going the next year.
Awesome. And I think, the perspective and the story that you bring up, especially with, kind of realizing and self-assessing and seeing how your program was and what are some of the strengths and limitations behind it. And then, kind of being exposed to kind of that next level through this can definitely make those continuing education and programs definitely seem to be an attractive option. And, Andrew, I'm kind of curious here. What are some questions that you, as a potential residency fellowship applicant, asked yourself to see if doing a residency fellowship was right for you?
I didn't think a lot of it at the time, other than I knew that there was a lot I didn't know. I'd been working about 4 years, I guess, before I did the residency. And I knew that there was so much that I didn't know. I'd taken a bunch of, weekend courses. I'd done McKenzie A and B. I had done some other, a foot ankle course here and a shoulder course there, and just sort of these piecemeal courses that kind of help a little bit. You learn some things, you learn a couple applications, you learn a couple techniques. But I just really felt that I know I didn't know enough. I didn't know when I didn't know. And it was that frustration of when patients weren't getting better. Was it because I didn't know something? And I wasn't sure at the time even how to go about doing more. I mean, I studied for the OCS exam and passed it after only being a clinician for a year and a half. But that didn't make me feel like I still knew any. I knew how to take a test well, but I didn't really still feel like a really skilled, knowledgeable clinician. And I wasn't sure where to get that information. And this is also now going back, 8 years, in that before really Twitter, before really these social media platforms, now that we have so much access to a variety of people and information. It was like, this is when the iPhone first just came out. And so I wasn't really sure how to go about doing it, but then I had it right in front of me doing this certification program, all this information that was just new and exciting and made sense, and I could see it, and it made sense logically. I could see how it applied, and it was really putting some of these pieces together. So I didn't even really ask so much questions other than how much was it going to cost and when could we start?
And, you talked a little bit about buying in, and the pun somewhat intended. What was the cost on that?
So the tuition cost for residency at the time, I want to say, was between $10,000 and $12,000. So definitely not inexpensive.
That's definitely an investment in yourself there for sure.
Yes. And that did not include any travel, because you had to do 150 hours, I think, for the residency of, and again, I was fortunate I didn't have to travel extra for the actual coursework, because it was in my clinic in Richmond. But I traveled to Seattle and Cleveland, go for a week at a time. So having to pay for travel, lodging, food, all that kind of stuff. So that was extra on top of that. One advantage is that there was no charge for, a lot of places will charge, fellows can charge for their mentoring hours. So they can charge if someone comes to them or if they go to them. But there's no charge within the Ola Grimsby Institute for the mentoring hours.
Well, speaking of that, let's talk about your residency program. Could you walk us through what the program entailed, from like the didactic learning portion to the mentorship, the teaching research, just to kind of give our listeners some perspective on what the structure of an orthopedic residency program actually looks like?
Sure. And I have to say that it has changed since I went through it, because actually the man, Rick Kring, who was my mentor and my instructor, is now actually the CEO of the Ola Grimsby Institute after Ola retired a couple years ago. So I know they have been doing a lot of work in terms of really restructuring and reformatting the curriculum. So I can't speak to what the state that it's in now, or I know it's going to be a little bit different. But at the time that I went through it, we essentially did a course, basically a weekend. We did 2 weekends a month, essentially, for about 10 to 11 months. I think 1 month, actually, we were there for 3 weekends, because it was a 5-weekend month, I think. So it was basically, 8 to 5, Saturday, Sunday. We got out a little early on Sunday, twice a month. Didactic just covered, basically, we went through all the different body regions, talking about anatomy, biomechanics, physiology, research into some of these things, learn techniques, learn variations of techniques. So it's basically, if you're doing cervical spine, it's like going to a cervical spine course for that, but that might be 2 weekends of cervical spine and then you have knee, and then so it's going through each sort of body region, because it was a manual therapy driven residency. But the nice component that was a little bit different than other manual therapy residencies and fellowships is that there was an exercise component within the Ola Grimsby Institute. There was something called MET, not muscle energy technique, but medical exercise therapy, that was developed by a gentleman named Oddvar Holten in Norway. And there's something called the Holten curve. Some people might be familiar with it, because it is taught I did actually learn a little bit about that when I was in PT school. But that was adopted by the Ola Grimsby Institute and then sort of rebranded into what's called STEP, or Scientific Therapeutic Exercise Progression. So there's a very large exercise component as well. So it's not just the manual aspect of it and the manual clinical reasoning. There's also an exercise component too. So it makes it a little bit more of a comprehensive, or at the time, a little more of a comprehensive treatment program, not just only manual therapy driven.
Gotcha. And, and Andrew, I know you kind of touched on the mentorship before with kind of those things. How many hours did you say you had to get? 130, 150?
I think it was 150 for the residency and then 130 for the fellowship. And basically what you had to do is go find either an instructor within the institute, or someone who's a fellow, or someone who's willing, you could go outside as well, but the challenge was they don't necessarily know the curriculum, the information, what you're supposed to know, how, the techniques might be a little bit different. So they encourage you to do it with someone who'd gone through the program. And so I actually went out to Seattle for most of my time, other than spending a week with my instructor at the clinic in Cleveland. I went out to Seattle because there were a group of instructors who owned several clinics in the Seattle area. And one of them, Jim Rivard, is now the head of AAOMPT right now, American Academy. And so there's a lot of instructors and fellows who work in those clinics. So going there, I would basically work in the clinic 50 hours a week and just spend time with 2 or 3. We had a primary sort of instructor, then I would be able to spend time with another couple of guys just to get a couple of different perspectives on things. And basically you're just with them in the clinic and you're helping them treat patients, and they're asking you questions, and they're kind of just observing how you're doing things and giving you feedback and questioning you. And because they kind of know the curriculum. So it's just really the practical application of what you're kind of learning in the didactic aspect of it. And then you're able to apply it in the clinic with an instructor.
Right. So kind of getting that overall didactic knowledge, then working on the psychomotor aspect, but then working on it, the kind of the clinical reasoning component with actual application with, instructors, and getting that real-time feedback. And Andrew, did you have to do any like research within the residency or anything like that?
So within the residency, it wasn't we did a literature review. So it wasn't necessarily independent research per se, but we did what was called a literature review, in that we chose a certain topic. We didn't do we didn't do necessarily like what would be a meta-analysis from a statistical standpoint, but really going through all the latest and greatest research on a certain topic and presenting it in a certain way. I had to write up a paper, present it. That was the main research part of things at the time.
Gotcha. No, I think that was a good summary overall of the residency program. But of course, after we have the completion of the residency, then comes sitting and being eligible for the board certification exam. And, with that being said, Andrew, what are your thoughts on the material tested on the OCS exam in terms of real world applicability and relevance in clinical practice?
So I'd done the OCS before doing the residency. So I already had that, and I had done that after a year and a half out of being out of PT school. So the residency doesn't prepare you at all for the OCS. And I did have a colleague who was trying to do both at the same time, and she didn't end up passing the OCS first time around because, again, the information is just totally separate. And she was told not to do that, but she was just kind of that personality, so went ahead and did it anyway. But it's my thoughts of it, if it's still any similar to the when I took it, however many years ago now, 9-10 years ago, it's not a good test. I mean, again, it's a multiple choice test. If it's going to be an orthopedic clinical residency, I feel like there should be some sort of lab practical component to it. But it's, the questions are very outdated. They're written in a way that a lot of times none of the answers are actually the correct answer. I was told I was able to find a prep course at the time, which at the time there was very, very few offered. And I was told, don't even look at research that's any more recent than 5 years, because the questions that are on the test are not going to be, because of the process of the question writing process, the questions aren't going to be updated with the more recent research. So I really came out of the test thinking it was a terrible exam, and really didn't do a good job of, I just don't think it's a good test. I don't think, like I said, if I can pass it after being a clinician for a year and a half or as little as I knew back then, I think that says enough that it's just not a really good test. That being said, I don't know I still don't understand what it gets you. That's sort of a separate question, I think, but I'm not sure what that gets you, other than the only thing I can think of that it was helpful in terms of it got me to kind of focus and study for 4 to 6 months with a couple of colleagues. And I probably learned a bunch of extra things by forcing myself to study. But there was no study guides. We had no, other than a weekend course that I took 3+ weeks before the actual exam, we were just kind of studying whatever we could figure out to study. And it was just whatever other resources we could find. That's what we kind of played around with, not knowing what we were actually going to be, what kind of benefit it was going to provide for us.
Yeah, Andrew, we hear that a lot with people involving the OCS, is that it's a little bit outdated. Getting those letters after your name doesn't necessarily mean anything. I think the one take-home message that we kind of hear throughout, though, is that the preparation and the study for it is really what makes you the better clinician. Now, again, back in the day when you took it, it wasn't necessarily as guided. I think nowadays there's a little bit more structure to how you can guide your studying. But how do you think the OCS then could maybe improve in order to help transition residents more appropriately to an evidence-based practice in this current day and age?
I think the OCS, it has to be essentially like, if you do a residency, you don't get anything for it. For example, if your goal is to be a fellow in the American Academy, you have to do a fellowship. Now, to do a fellowship, not everybody, but most places require some sort of residency. It's unless people accept the OCS as a residency equivalent, which it is in no way, in my opinion, even close to being a residency equivalent. But I think if you want to call someone a board-certified orthopedic clinical specialist, they should at the very least have gone through a residency. And for that, there has to be some consistency among residency programs in terms of some core information that is imparted. And then obviously there's going to be a little bit of, Mackenzie's going to have a residency, and Ola Grimsby has a residency, and EIM has a residency. So they're all going to have their own unique way that they want to teach things, and techniques that they want to teach, and clinical reasoning strategies they want to teach. But there still should be some, I think, sort of those core basic things that are consistent among residency programs, that then you can say everyone has met this minimum criteria. Because if not all are created equal, then how can we base sort of the quality of clinician?
Yeah, Andrew, I think that's a really important point for our listeners to hear. Kind of hearing that variability that exists within these different types of residency programs is definitely a strong consideration and something that we should be aware of. And kind of going off of that, I know that's one aspect of it, but what are some of the other critiques or limitations that you found from your residency training?
Well, I think it's, look, now it's at this point of knowing what I know now, looking back, what are some of the critiques at the time. The way I tend to learn things is I just kind of go all in, learn it, and then later it's having to go back and kind of figure out what is the looking at use Bruce Lee quote as an example is absorb what is useful, discard what is not, add what is uniquely your own. But you can't really do that until you've immersed yourself and really understood the information and all that goes with it before you can figure out how you can operate outside of it. So at the time, I just immersed myself totally, absorbed it, and just kind of went with it 100%. And then based on that, looking back, you can see, okay, these are where some limitations are. This is what I don't use a lot of it in a regular clinical practice. I think some of it is nice for ideal situations, not necessarily always for real world situations. It was definitely heavy in biomechanics, which I think is important to know because it's good to know the joint planes and the angles and these kinds of things in detail, because then once you really know it, you can also adapt to it for each individual patient. There wasn't a lot of pain science in the sense of what we kind of have learned about it over the past 5 years, but there was some introduction of dorsal horn inhibition, segmental facilitation, central sensitization, a neurophysiological basis for the development of certain situations, not purely a pathoanatomical basis. A lot of the research at the time that they emphasized within the Ola Grimsby Institute was a little bit older research, not as much from a lot of the newer things. It had not been fully updated at the time, and it was some of the with the exercise component. A lot of it is really nice in the clinic, but it doesn't necessarily translate very easily to home exercises because it requires not a lot of equipment, but a little bit more of an elaborate kind of setup. And it's definitely not very user-friendly for a lot of people.
Yeah, I love that take on it, Andrew. If you looked at this then from the perspective of you had to create the perfect roadmap for a residency or fellowship program, how would these critiques and limitations be addressed in that roadmap?
So, I mean, it's hard because, just trying to imagine how much time it takes to set up an entire curriculum. It's not like you're not just making one course for the one weekend course. It's, you're creating a whole system, ideology, so to speak, approach. And you have to set that up for looking at a whole, 1 to 2 year kind of curriculum. So I can imagine that when you have things a certain way and a certain understanding, and you have established sort of a institution, you have established instructors who've been learning things a certain way, and then things are changing, and we see the pendulum swinging a lot these days, for better or worse, towards a lot more of the, for lack of a better word, pain science and the power of the brain and the nervous system, and moving away from a lot of pathoanatomical stuff, which I don't think we should necessarily move too far away from. But that's always a problem. Sometimes the pendulum swings a little bit too far in one direction, and we got to bring it back. But I think that it has to still employ, if it's going to be, for example, a manual therapy program, there's still the emphasis on manual therapy. I think there is something to be said for having good technique, good confident hands, knowing what you're doing, being very specific and rigid in terms of how you learn certain things, with also the understanding that not everything has to be actually performed in the clinic in a rigid and dogmatic way. There has to be freedom to make adjustments based on individual situations, whether it's a clinical situation or in certain characteristics within the patient. And also that the clinical reasoning aspect really needs to be emphasized even more so. I think with a lot of the stuff that, with my growing relationship with Jerry Durham, really getting into some of the patient experience type things, learning how to manage expectations, teaching some of the soft skills, which I think there was a time where we thought it's not something that could be taught. But I think I'm a living example of someone who can learn these skills, who some of them don't always come naturally in certain ways. So I think being able to incorporate the manual skills, the patient management or patient relationship skill aspect of things, sort of that emotional intelligence, if you will, incorporating pain science, things that talking about pathoanatomy, talking about biomechanics, having, a good understanding of exercise principles. I mean, these are all the things that have to be in if you want to really have a really well-rounded program to create really knowledgeable, well-rounded clinicians.
Yeah, Andrew, that's a beautiful take on there, man. And I appreciate kind of what you were saying and that, and really bringing up some of those concerns and that. I think that was very helpful. And, I'm going to go back a little bit now and kind of switch to kind of going more towards the fellowship route. And, do you think you could kind of walk us through what the fellowship program entailed, kind of from the didactic mentorship and kind of what you had to do with being in the fellowship program?
So the fellowship program was actually, after the residency program being as sort of intense as it was with, 2 weekends a month for 10, 11 months, the fellowship program, the residency is really where you get like the big bulk of the didactic information. And then the fellowship through the Ola Grimsby Institute at the time was really more fine tuning, really not just from the hands-on techniques, but then even from the didactic stuff. So it was a little bit less intense. It was mostly 1 weekend a month for about a year. A couple months had a couple weekends per month. So instead of like 22 weekends, it ended up being maybe 14 weekends, something like that. It was still 130 one-on-one hours, but it was really, kind of going over the techniques, fine tuning, really coming, because you're thrown so much the residency, it's hard to put it really well and confident into practice, because some of the exercise concepts can be a little bit challenging to get your head around, along with everything else that you're doing, because it's just kind of go, go, go. So it really was a chance to kind of slow down a little bit, like fine tune, pull in some clinical reasoning, see how some of the pieces put together, spending a little bit more time with the exercise component. And there's more, there's more some of the thrust manipulation techniques. There's more advanced techniques, more advanced kind of the reasoning process into, a lot of the ideas through the Ola Grimsby Institute was trying to figure out what the tissue and lesion was. And so we can argue about that, and that being whether that's even possible or not, due to what we know now, more recently, especially when it comes to pain. But the clinical, that was sort of the thought at the time, is that can we determine whether it's a disc, a facet joint, a ligament, a muscle tendon, this kind of thing. So the clinical reasoning process from the biomechanical pathoanatomical standpoint, fine tuning, that was really what the fellowship ultimately did.
Gotcha. So kind of taking the skills that you learned in there and kind of really upgrading it, fine tuning it, and really kind of getting more into the application. I think that's a good take. And And Andrew, I got to ask you this question here, just because I'm kind of curious on this one here. Will you renew your fellowship OCS when it is due, and why or why not?
So OCS, I'm not going to renew unless I find out later, of course, it's required for the fellowship. I need to look into that, but I'm kind of lazy when it comes to these things, so I don't know. As for the OCS, I see no reason for me to renew it unless I want to just take a pile of money and light it on fire, because I don't know what does it get me? What's the purpose of it? No one's answered that question with any clarity for me, because it's just paying however much money it is, $1,000 or so more dollars just for 3 letters, of which no one cares about other than other physical therapists to use as somewhat of a status symbol. So at this point, I don't need or care about letters, so there's no reason why I'm going to renew it. As for the fellowship, yes, I'd renew because I like being active in the American Academy. I like having access to the information. I like being part of, the educational aspect of things. I want to be part of advanced education in the profession. And I think residency and fellowship, at least in outpatient orthopedic practice, is something that should be required of outpatient orthopedic clinicians, similar to the medical model, in that some sort of residency fellowship type thing should be required in that arena.
I love it, Andrew. Thank you so much for taking the time to talk with us tonight and providing some great insight to our listeners on residency and fellowship. We like to end every episode with this question to each of our guests. If you could change one aspect of healthcare education, DPT or other healthcare provider related, what aspect would you change and how would you change it?
Oh, geez. Only one?
No, go ham at it, man.
I think the entire curriculum of the DPT program has to change. And I kind of like what I'm seeing, what EIM is doing at South College, and it sounds like Baylor is starting to do with sort of the accelerated programs, in that if you want to still keep it a 3-year program, then almost like, you have sort of like your gen eds in undergrad, and you have sort of your gen ed, so to speak, in PT school for what is going to be, preparing you for the board exam. But then you essentially have to choose a track. Are you going to go outpatient ortho? Are you going to go acute? Are you going to go peds? Are you going to go neuro, spinal cord injury, whatever? You choose your track, and then that's where you spend that last year just immersed in. So if it's outpatient orthopedics, you're essentially spending a year immersed in outpatient orthopedics, and you're getting, you're really going even more in detail into the kinesiology, the biomechanics, the anatomy, pathophysiology, pain science, hands-on treatment, exercise, both didactically and spending time in clinics. And then you basically get a job, so to speak, but you're also doing your residency in that first year out of PT school, and that serves as your residency year, but you're still getting paid at that time, just not maybe a full salary. That's just sort of a 30,000 foot view of what I think would be a good model going forward.
Yeah, no, I think that's a good point, Andrew. And it was interesting when we had Kathy Myrella on not too long ago, who was the head of the Best Practice and Physical Therapist Clinical Education Task Force, and how kind of what their suggestion in terms of that was kind of similar to what you said. And, and the big thing that she kind of mentioned that she wanted to really emphasize was that these transitions would not increase student debt. So they try to find some way to keep it kind of at least where it is at the minute, if they could. But the goal on there was to ultimately not increase any kind of student debt in any way, shape, or form. So I think that was interesting to hear.
Well, I think that's huge, because, the program's got to be, if you're going to keep it 3 years, you keep it 3 years. So it should not change the financial cost of the students, unless, if you make it a shorter program, it should make it less expensive. But that way, being that it's not really a 4th year, you're still a 3-year program, but then you get a job working wherever you get a job, but you're making money, but you're also still doing a residency type program, and the way the financials work out between you and your employer or the program that you're going it through.
Yeah, no, absolutely, and I think that's a good take, man. And thanks so much again for coming on and for everything, Andrew. And where can our listeners find you online and on social media?
So I'm on Twitter at @Rothschild PT, and also that's the same on Instagram. Those are the two best places, Instagram and pretty active on Twitter. And occasionally you can find me co-hosting the Healthcare Disruption podcast with Jerry Durham.
Yeah, I love it. When's the next one coming out for that, man? Do you know?
Excellent question. We'll have to talk to Jerry.
There we go. We just got to go hassle Jerry Durham some more. Well, thank you again, man, for everything. And from all of us here, have a good night, everyone.
Thank you.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.